Bismillahirrahmanirrahim. The college has assigned me to deliver to you a presentation on this important topic of delirium. This is my first presentation as a medical educator. I assume most of you do not know me, so let me briefly introduce myself. I'm Dr. Waleed Ahmad. I'm a fellow of the College of Physicians and Surgeons, Pakistan, and honored to be working as the senior registrar in the Department of Psychiatry at Peshawar Medical College and Mercy Teaching Hospital. I completed my graduation from Khyber Medical College in 2013 and completed my fellowship in psychiatry in 2019. So with that, let's begin with the topic that has been assigned to me today. Here is the definition of the delirium from the Short Oxford Textbook of Psychiatry. It says, delirium is a global impairment of consciousness that results in a reduced level of alertness, attention, perception of the environment, and then cognitive performance. So there are several terms used in this definition that can make it difficult to comprehend at first. It begins with the clouding of consciousness that they say result in a reduced attention, alertness, perception. These are the cognitive, or let's put it simple, mental abilities. So the overall mental abilities or the cognitive performance is reduced. So let me quickly explain these terms so um, you can fully comprehend this definition and the other signs and symptoms of delirium that we'll be discussing later. Perception occurs when the brain processes the raw sensory stimuli from the environment to generate some meaningful information. For example, the light packets or the photons or the sensory data that through the eyes and the optic tract reaches the visual cortex, which processes it to form an image. Similarly, sound waves are processed by the brain, so we hear voices that contain information. It's interesting and can be deceptive. Here, for example, we are seeing an apple jumping and rotating in a 3D space, even though the screen is actually flat. So we are perceiving the light emitted from the screen, which is the actual sensory data, as a 3D rotating apple. Attention is a mental capacity to hold information actively in mind for processing. For example, mental manipulation, interference, making sense of information, making decisions based on it, etc. It has a limited capacity. In an average, we can keep 7 digits in mind at the same time. The ability to sustain this attention is concentration. For example, if you start counting backwards from 1000, so how long you can do it without making a mistake? And distractibility is a related term. It is simply the inverse of our ability to filter out the irrelevant stimuli and to focus on the relevant ones. Now, these are some but not all of the cognitive functions, and these depend on the level of alertness. So when a condition impairs alertness, these functions are reduced and eventually pause. The patient appears in a sleep-like state, and we call this stupor. These patients can still respond to at least some stimuli, and when they stop responding to stimuli, so we say they're comatose. Now, any level of consciousness between complete alertness and stupor is what we call a clouding of consciousness. Now let's have a look at this definition again. A global clouding of consciousness resulting in a reduced level of alertness, attention, perception of the environment, and thence cognitive performance. So now we can clearly understand that. One important point about this definition is that it never mentions any cause, unlike conditions, for example, COVID-19, where we have to find the evidence of its causative agent. Delirium is only defined by its clinical manifestations, because the causes of delirium are multiple. Delirium has a wide range of manifestations, but there are some core features which are central to the diagnosis of delirium, and the course of the symptoms is also important. The core features include a clouding or impairment of consciousness, visual misperceptions and hallucinations, reversal of the sleep-wake cycle, and variability of the symptoms over the span of the day. A rapid onset is also important from diagnostic point of view. So we already described clouding of consciousness. The definition of delirium begins with a mention of the clouding of consciousness or the impairment of consciousness. It is the hallmark of delirium, and we also described its manifestations. But one important manifestation is the disorientation in time, place, and person. The patient does not know the people around, where they are or where they come from, and they are not aware of the date and the time as well. A rapid onset also has a diagnostic importance. And a further clue to the diagnosis is that the onset has a temporal relationship with the cause. We'll describe it later, but this rapid onset is most important to differentiate delirium from dementia. The majority of the symptoms that occur in delirium also occur in dementia, and in that case, they arise over the years. So that's a differentiating factor, because in delirium, the onset is usually within hours to just a few days. The symptoms of delirium change over the span of the day. Severity may intensify at night and then ease in the daytime. Some symptoms may subside, new symptoms may arise, and this variability of the clinical picture is another diagnostic feature of delirium. Patients also show a reversal of the sleep-wake cycle. They may sleep in the day and stay awake at night, and that could be one reason why the symptoms appear to worsen at night. But just remember that sleep-wake cycle, its reversal is also important for diagnosis. We already described perception and we said it is reduced in delirium. Illusions and hallucinations are abnormalities of perception. An illusion occurs when we misperceive a stimulus. In most cases, it is a visual stimulus. For example, seeing a full-sized car sitting on a table when in reality the car stands on the floor way behind the table. It's mostly a normal phenomenon. But also note that a stimulus is present, but we misinterpret it. Sometimes people perceive things without an actual stimulus, like hearing voices or seeing something that others can't see, and we call these hallucinations. So, perception without an actual stimulus is hallucination. It is frequently an abnormal phenomenon. Hallucinations occur principally in the visual and auditory modality, but uncommonly they can even be tactile, which refers to the sense of touch, or olfactory, the sense of smell, or even the sense of taste. Patients with the delirium can experience illusions or visual misperceptions, like misinterpreting a stethoscope for a snake, and hallucinations like seeing a giant scorpion hanging from the ceiling or some insects crawling on the skin. Note that patients with psychiatric disorders like schizophrenia experience auditory hallucinations, but patients with delirium experience visual hallucinations and visual misperceptions. And these visual misperceptions are another diagnostic feature of delirium. One possible reason why patients with organic mental disorders experience visual hallucinations is a disturbance of acetylcholine. Acetylcholine is a neurotransmitter in the brain and has an important role in cognition, and its depletion is linked with visual hallucinations as well. And for some reason, organic conditions with mental symptoms tend to have impairments in acetylcholine. So take for example delirium itself, Parkinson's disease, dementia, even anticholinergic medications can cause both visual hallucinations and cognitive impairment. And cholinergic medication is used to treat Parkinson's disease psychosis which presents with visual hallucinations. So these are the core symptoms of delirium, but actually almost any psychotic symptom can occur in delirium. There are some symptoms that are relatively more common though, especially the disturbances of thought and mood symptoms. Thinking may be slow and muddled, that is vague and confused. Patients also exhibit delusions or ideas of reference. Previously we said illusions are mostly normal, hallucinations mostly abnormal, but a delusion is something that is always abnormal. If it is normal, so it cannot be a delusion. It has a stringent definition. So a delusion is an unshakable belief, that is, we cannot modify it with logical explanations or even evidence, and that is held on inadequate ground. So they do not have any valid explanation or evidence for their belief. And that's not a conventional belief that the person might be expected to hold given their educational, cultural, or religious background. So, someone who believes to be possessed by the supernatural is not deluded because it's a culturally common belief. In the West, many girls, young girls, they become convinced that they need to be thin, take extreme measures, and they, their weight may reach life-threatening low levels, and they may still continue. And this is still not a delusion because the thinness is considered socially desirable, and then most people are educated about the risks of obesity, that it's dangerous, and the need for thinness. Persecutory delusions are the most common ones in which they develop a belief that someone wants to harm them. An idea of a reference is a related term. It refers to an unnecessary tendency to link external events, things, or people to self. For example, someone enters the room and patient thinks that he has come to kill me. If this idea meets the criteria for a delusion, so then we call it a delusion of reference. Mood symptoms also occur, and they do not have a diagnostic significance, but they're very important from the management point of view. These include, for example, fear, anxiety, depression, like, sadness, weeping spells. These symptoms are often secondary to, or at least are made worse by the primary symptoms like clouding of consciousness. Epidemiology deals with the distribution of diseases or health conditions in various ethnic, age groups, socioeconomic groups, geographies. Some of these groups have higher rates, or we can say they have a higher predisposition for developing that condition. Now, these factors are not mutually exclusive, that is, they can overlap. For example, delirium is more common in the elderly. It is also more common in those who are hospitalized. So, hospitalized elderly is included in both these groups, or again, we can say he is predisposing risk factors for delirium. People with more of these risk factors are more likely to develop the condition. Now, patients with certain medical conditions may also be predisposed to develop a condition, and these are not epidemiological factors, but I have included them here so you can learn the predisposing factors together. The most important demographic risk factor is old age. Alcohol users are also at an elevated risk, as are people with functional impairment. Think about an elderly woman in a wheelchair who broke her leg and needs help from caretakers. To help you precisely understand, impairment is used in medical terms for the pathological defect or disease, and the loss of function as a result of this defect is the functional impairment. So, a broken leg is an impairment, and the inability to walk, the need for a wheelchair, or help with self care needs is the functional impairment. So, if this elderly also had a long term history of alcohol use, she would have all these demographic risk factors, just so you can remember. Now, let's assume she develops delirium and comes to you for assessment, and you find that she also had developed dementia due to long term alcohol use. And as you assess her further, you discover that she broke her leg because she fell due to a brain stroke. And as a result of that brain stroke, she also lost her eyesight. So that makes her more likely to experience another episode because if she had delirium once, she can have it again. Her cerebral reserve or simply brain volume is reduced because dementia reduces the brain volume. Dementia causes brain atrophy or loss of the brain volume. And then she lost part of her cerebral cortex to the stroke due to, say, an infarct, and which also took away her eyesight, which is a sensory impairment. So these are all the medical predisposing risk factors for delirium. So now that the patient is at an even higher risk for delirium, Let's assume she comes to you with a third episode of delirium while you're working in the emergency department, and after the emergency management, you admit her to the medical unit. When she improves, you send her to the residential home instead. So now she's at an even higher risk for another episode. Elderly in the community are at a higher risk of delirium, but the risk in the residential homes is even higher, around 4 times more higher. So, and then as higher as 1 in 8 patients who present to the emergency department have delirium. Patients who are admitted to the hospital are even more likely to have delirium because this makes sense. We only admit those patients who are relatively more seriously ill. So you can understand, especially those who are admitted to the medical units, because medical conditions are some of the more common causes uh, of delirium that we'll discuss later, compared to, for example, those who have psychiatric illnesses or diseases of the eye, the nose, etc. Um, there is no mention, but patients in the ICU, particularly the medical ICU, they are also very highly likely to have delirium. Etiology refers to all the factors and the processes that eventually lead to the disease, and every condition is caused by multiple of these factors. Let's take COVID-19 for example. Is it the virus or is it its pathogenicity that's most important? And what about our lack of immunity to it? What about the risky behaviors like exposing yourselves or the faulty ways of thinking like I'm not going to get it? So the virus is the causative factor, its pathogenicity is part of the pathophysiology, and our lack of immunity is the predisposing factor. The faulty ways of thinking and the risky behaviors are um, risk factors which can be predisposing, but when they eventually trigger the disease, so they are known as precipitating factors. And these factors are collectively known as etiological factors. In the case of delirium, the causative factors are especially diverse, as we'll see. There are also some known facts about the pathophysiology. Even for the individual cases, the etiology involves multiple factors most of the time. For example, an elderly man with uncontrolled diabetes who suffers cardiac failure is admitted to the CCU where he's started on steroids and digoxin. But note that some cases may even be idiopathic. That is, we do not know what caused delirium in this patient. These cases require the most careful workup because the treatment of the underlying cause is most important for outcome. In the elderly admitted to the hospital, drugs and infection are the most frequent causes of delirium. To help you remember them easily, we can group the causes into drugs of abuse, medications, medical conditions, and physiological abnormalities. Some of the common drugs of abuse include alcohol, benzodiazepines, opioids. Alcohol and benzodiazepine withdrawal is associated with a special type of delirium that we call delirium tremens. Apart from the general symptoms of delirium, delirium tremens is characterized by an autonomic instability like irregular heart rate. Epileptic fits may also occur, and the prognosis of delirium tremens is even worse. Uh, One important point to note is that people use benzodiazepines as their regular sleeping pills, and they may attempt to withdraw from them on their own because they don't really see it as a serious risk to their health. And then these patients could present as idiopathic cases of delirium. So it's important to ask about benzodiazepines in such cases. A long list of medications can also cause delirium, but the most common ones are those with sedative properties, medications with anticholinergic properties, steroids, and digoxin. So while evaluating delirium, always look whether the patient is receiving any of these medications. But since the list is extensive, the best way is to cut down on the doses and the number of medications to a bare minimum in all of the cases. Many conditions can cause delirium. But septicemia, high degree fever, organ failure like renal failure, liver failure, or even cardiac failure are among the common ones. As a rule of thumb, delirium has a temporal relationship with its cause. So, if someone develops a medical condition and then they develop a delirium, so we might assume that as a cause. These are some interesting causes, especially important for idiopathic delirium where no cause is evident. Sleep deprivation, for example, may not reveal unless we inquire about it. And similarly, um, keep constipation and dehydration in mind. In some cases, mental trauma and extreme physical pain may also induce delirium. These were the common causes of delirium, but again, remember the list is extensive. The pathophysiology of delirium is less well understood, but we know a few factors about the findings on electroencephalography, neurotransmitters, and there are some other factors. There is, for example, slowing of background activity on the electroencephalography, which is like the cerebral variant of electrocardiography. It measures the electrical activity of the brain. So there is a slowing of the background activity or slowing of the overall activity, and this slowdown is inversely related to the severity of the symptoms. So when the symptoms are more severe, the slowdown of the activity is also more prominent. Dopamine and acetylcholine are involved in the final common pathway. We already talked about acetylcholine. Dopamine is also a central nervous system stimulant neurotransmitter, and it also has role in cognition and hallucinations, and this time auditory hallucinations, but also in delusions. You can simply remember this with the D of the dopamine for the D in the delusions and the D in the auditory hallucinations. You'll learn more about it in another lesson on schizophrenia where it has a more prominent role. A range of other factors are also implicated, which include inflammatory, metabolic, and genetic factors. We will not discuss these. This is the end of the etiology section. The clinical assessment includes general history and bedside testing, including, in this case, particularly the mental state or the cognitive examination. On history, we inquire about the major symptoms of delirium that we just discussed. For example, whether they experience visual hallucinations, and we also elicit the course to confirm its rapid onset and its temporal association with its cause, identify the fluctuation in symptoms and whether the symptoms worsen at night. Reversal of the sleep-wake cycle is also relevant here. During history, we already develop an impression of whether the patient appears drowsy. So we begin by testing orientation to time, place, and person. Simply assess whether the patient is aware about the location, the date and time, and whether they can recognize the people around. So that's how you test orientation. Here's a random number. Listen to it and then repeat after me. 3951. So if you could repeat, that means your attention span is at least 4 digits. This is the lower limit of normal attention span. So if a patient can do this, you can skip further. But generally, attention span is tested with 7-digit span test, in which we follow with more random numbers. Next time we give them a 5-digit number, then another random 6-digit number, and finally we give them a 7-digit random number, but each time the number has to be different. For testing concentration, we ask them to subtract 7 from 100 and then keep subtracting 7s from the answer each time for a total of 5 times. So we are not testing math here. We want to see if they can perform a mental action repeatedly without losing the focus. So you can give them an alternative task. For example, starting with 30, subtracting 3 from the answer each time, or speak the days of the week in reverse. That was bedside testing. Now, there are two investigations that can also help us in the diagnosis. Again, it's a clinical diagnosis, but these investigations can help us when the diagnosis is in doubt. but they are still not widely used, and I'll explain why. We already explained the inverse relationship between the severity of the clinical presentation and the background activity on the EEG. So this is one thing that can add, but it's not very sensitive or specific. The most sensitive and specific test is the confusion assessment method. It is a clinical tool that can be used to evaluate patients on the bedside, and it takes only 2 minutes to apply. It is not much different from the clinical assessment, that's why it is not much widely used, but it has standardized the whole process, so it can be very useful for learning. When you practice on it for a few times, you can do the same mentally then. If you want, you can download it from that link. This was about the diagnostic assessment of delirium. The assessment of the underlying cause must be even more careful and thorough, particularly in those cases in whom the cause is unknown. A thorough medical history, physical examination, and investigations are mandatory for that. And the assessment varies case by case, just as in most cases, we tailor a physical examination based on the history and the lab investigations based on both of these. And then we can go back and forth until we find the exact cause. Idiopathic delirium requires the most attention, and in those cases, it is wise to start with causes that are likely to be overlooked. For example, whether the patient is on a catheter, which is a common practice in medical units. The use of physical restraints is not very common, but keep them in mind as well. Inquire about constipation and whether they have been sleeping well. Again, a very easily missed cause of delirium. Patients are frequently secretive about their drug use, or in the case of benzodiazepine, they may not consider it as a serious risk. So look for other signs of drug withdrawal in such cases. Pain can also cause delirium, so keep that in mind. And check for dehydration with a skin pinch. But after these, the assessment should not stop there because the causes are extensive, and so we should keep assessing until we find the exact cause. So that was about the assessment. But in this next section, we'll discuss the remainder of the management focused on the preventive and the therapeutic interventions. Treating the underlying cause is the most important part of the management because the outcome depends on it. But preventive therapies are even more important because obviously no delirium is preferable to delirium, but also preventive therapies are more effective than therapeutic. Uh, we have some non-pharmacological and some pharmacological interventions to prevent delirium. Help and eliminating the risk factors are among the non-pharmacological interventions. HELP is a structured program which studies have shown effective in preventing delirium. It's a commercial product from the American College of Geriatrics that costs around $5,000 for a 2-year subscription. Eliminating the risk factors is the most feasible option. Target those who are highly predisposed. Think about the elderly who lost eyesight, broke her leg due to a fall, now hospitalized with multiple pathologies, receiving multiple medications, including anti-dementia treatment. So find a list and think about what can be avoided in this patient. Effective pharmacological treatments include antipsychotics in low dose, gabapentin, melatonin. Several antipsychotics have anticholinergic and sedative properties. Haloperidol is a good option. Gabapentin is an anti-epileptic which also helps. And you can remember melatonin because this is the hormone that regulates the sleep-wake cycle. Remember the sleep-wake cycle reversal in delirium. The World Health Organization has classified delirium with mental and behavioral disorders. So it is not recognized as a medical condition, but it is still a medical emergency because the underlying cause is almost always organic. Most importantly, the mortality is high, and as such, it requires urgent medical attention because the prognosis depends on the treatment of the underlying cause. So a careful workup is required to identify these underlying causes, especially when they are not evident. The aim of the psychiatric management is to relieve distress, control agitation, prevent exhaustion that can occur as a result of the restlessness, the agitated behavior. We have some pharmacological and some non-pharmacological treatment options. The non-pharmacological treatments are actually the mainstay of treatment, while the pharmacological treatments are reserved for those with severe agitation and hallucinations. We know clouding of consciousness is the hallmark of delirium, which results in poor cognition, disorientation to time, place, and person, confusion. So imagine you do not know where you are, everyone seems a stranger, you are not aware of the time, and add to that the experience of frightening hallucinations like seeing scorpions and snakes. So that's more like a nightmare, and so the patients become anxious, agitated, uh, which is most common indication for psychiatric treatment. So the most effective way to treat it is to target these core manifestations. Confused patients may be asking questions, so we gave them frequent explanations. They do not know where or who they are, the people around, so we reorient them frequently. Ideally, they should be nursed in a single quiet room, and if possible, the same staff, the same clinician should take care of them. Relatives should be encouraged to visit more frequently, and at night, the lighting should be enough to allow orientation but not too much to impair sleep. And finally, for hallucination, if possible, is they see snakes, so we reassure them that they can see them, but that they're not real. They're part of your illness. We do not deny them, but we tell them that they're part of your illness. Antipsychotics are the first line pharmacological treatment, but their use is limited by their side effects, especially sedation and anticholinergic effects. So they are only used to control severe agitation and improve sleep. Haloperidol in a very low dose is most commonly used for this purpose because it has a suitable effect and side effect profile for its use in delirium. Regarding the mortality, around 1 in 4 patients may die over the next 3 months. But just to be clear, mortality is not the same as case fatality. Mortality is always expressed with a period of time in a specific population. In this case, it also is the crude death rate because the actual causes are always multiple. Case fatality is a specific cause mortality, so we can never relate it to delirium because delirium is never the cause of death. Also, the risk of death doubles over the next 2 years after an episode of delirium. Again, this is the standardized mortality ratio, the rate of death in the patients with delirium compared to its rate in the general population. Delirium has a complex relationship with dementia. As we discussed, dementia predisposes to delirium. Similarly, delirium increases the risk of dementia. So it's a bidirectional relationship. But delirium also acts synergistically with the underlying neuropathology of dementia and increases the risk of the cognitive decline. So it accelerates the process of dementia as well. The elderly, people with dementia or physical illness, they have a poor outcome, which makes sense because in old age, people have already become physically weak. Similarly, we just said delirium accelerates the rate of dementia, so we can understand that. And people with a pre-existing physical illness, for example, asthma, are more likely to die from the condition that caused delirium. That's the end of the presentation. I hope you all learned from it. Thank you for being attentive.